much. So it's a privilege to be here in the United States as a simple ENT surgeon between you. And this morning, I will try to speak about the anatomy of the facial nerve, which sometimes can be an important problem for you as well. I used to find this nerve when I make a parotidectomy, salivary gland surgery mostly. The study has been done, even though I worked in France, in Champagne area, in Budapest, Hungary, at the University of Technology, and in cooperation with the University Medical School of Budapest. The study is an ex vivo anatomical study, a descriptive study. Voilà. Okay, so on the first slide you can see a citation of Professor Peabody from 1927. Nowadays you would call this phrase a description of quality of life. At that time he said what is spoken of as a clinical picture is not just a photograph of a sick man in bed, it is an impressionistic painting of the patient surrounded by his home, his work, his relations, his friends, his joys, sorrows, hopes, and fears. So with this slide, I would like to say that with facial nerve damage, paralysis, your life can be destroyed. So we have to look for a technician, maybe. Bon, je vais chercher le technicien. Okay, d'accord. So on the first two slides, I just show you cases of facial paralysis, the periphery type of facial paralysis. These pictures, images, you see them in your everyday activity. This gentleman had a cancer of the external ear. You can see the difference when he's trying to close your eyes, especially. Facial paralysis may occur even in childhood, as in the case of this boy. So the former case was a cancer. This was a paralysis of the bell type, idiopathic paralysis. How about facial paralysis? History and traveling. Our Chinese colleagues finally didn't arrive, but this is a mask which is about 200 years old from China, and it shows the importance of facial paralysis. The signs are very nicely marked on the frontal area, the eyes, the nasolabial sulcus, and the mouth as well. Facial asymmetry was recognized in Europe as well. This is a statue of Rodin. You should go to see the Rodin Museum in downtown, which is beautiful. The asymmetry is very nicely marked, but it's a kind of trick on my part because there's no facial paralysis. The statue is called the broken nose, and the asymmetry is due to pain only. To travel a bit further, this is an image from Africa 2 years ago, and you can see the difference, the asymmetry of the mouth. Is there any facial paralysis? What do you think? Who is voting yes? Ibrahim says there's no facial paralysis, and he's right, there is no facial paralysis. In fact, this is a traditional hero, a shaman, who is preparing to get into a trance, and for this reason, he's eating a razor blade, and he drank some gin after. Okay, so just to repeat a little bit about the anatomy of the facial nerve, it has several sections. Leaving the brain, it passes intracranially about 2–2.5 centimeters, and this part is very vulnerable. There's no epineurial envelope. Then it enters the bony meatus for about 1 centimeter together with the 8th cranial nerve. Then at the area of the ear, it's about 5 millimeters long, and an important part can be found here, the ganglion geniculata, From this part, it's really covered by epineurial envelope, which is protecting the nerve, but also in case of edema can be a contributing factor of paralysis. The nerve passes through the bony canal, the tympanic and mastoid parts, and then it leaves the crane and goes extratemporally. Just to show you some of the slides which has all been done in Budapest at the University of Pathology and Anatomy School. So this is the brain and the pontocerebellar angle where the facial nerve leaves the brain, goes to the meatus, and together with the hearing nerve and the vestibular nerve. This is a CT scan of the bony canal when it passes under the horizontal canal, goes backwards, then turns down till towards the stylomastoid foramen. I have made this preparation to make an illustration of these relationships. So the horizontal canal, the hearing bones, this is the second, and this is the first, the third, the stapes, and the nerve is passing through. On this slide, the bone has been taken off the canal and the nerve itself. So it leaves the skull at the stylomastoid foramen with a trunk, and then gives two major branches, usually two major branches, the upper division and the down division, the upper for the frontal eye and buccal areas, down to the buccal, mandibular, and cervical areas. Here, just for the curiosity, you can see the chorda tympani, which is providing taste sensation. It leaves the nerves, and behind the tympanic membrane goes to the middle ear before going towards the tongue. No. So on this image, you can see the branching of the nerve over the mandibula. And yesterday we have seen a very nice presentation about the mesenteric muscle. Here you can see its fibers. You can see how rich this herborization is. And finally, it goes to the muscles of the face, like the orbicular muscle, the zygomatic muscle, the perioral muscles, the depressor of the angle of the mouth, and the cervical muscles. As you have seen, the branching pattern is very complex, and several studies and classifications were done. The most well-known classifications are of Davis, Milka, and Katz. Actually, none of them are complete, and there are always exceptions. So usually the most simple case is when there's no anastomosis of the branches at all, and complex multiple anastomosis is level 5, 6, or in the classification of Milka is level 8. How about the branches, the numbers? As you have seen 3 diapositives before, the nerve enters the parotid gland, and approaching the periphery, the muscles, the number of the branches gets higher. So according to a very nice study from 2010 by Zafeta and Terzis, it's around 7-8 branches in the gland, and when it approaches the muscles, it's almost 14. This was a Western European population. Several other studies were done, mostly in Brazil and the Philippines and China. Our study was done using a Hungarian population. So this was the first Central European study. Okay, so just to have an idea about the numbers, the zygomatic branches and the buccal branches approaching the muscles of the eye and the buccal area have quite a high number. while the temporal branches and the marginal mandibular branch usually has a lower number. I had the chance to work with Professor Becske in Hungary, where Tamás has worked as well. And even 8 years ago, they have told us that there's only one and only marginal mandibular branch. So if you cut it, game over. In this study, they have found an average of 2.3 branches. So now I will try to show you some examples. Here you can see a bifurcation of the mandibular nerve, anastomosis of the temporofacial branches, and it was just a trick when checking at the numbers of the branches. We cut the nerve at the stylomastoid foramen to raise it, because sometimes the branches are so attached that you would say that's only one, and when you raise it, there are 2 or 3 branches, so it's 3. Here you can see complex anastomosis, lower division, the marginal branch and the buccal branch, and also a loop of the marginal area, and the second anastomosis a bit further. So another nice example of the anastomosing structures, 1, 2, 3, 4 anastomosis can be seen on this image. And even if there's only one mandibular branch, an anastomosis that touches the nerve after the cut surface can provide recoming of the function. Another nice example with anastomosing branches. Yes. And this is quite a nice one. This is a loop of the mandibular branch. There's no other anastomosis or collateral branch, but there's a nice loop here. So if you cut at this part, you have a chance that the function will be revealed by the other part. When you are achieving cadaver dissections, of course, you have difficulties. The most important is you have to start at 6 o'clock in the morning, and when the students arrive, you have to finish at 8, so you're in a hurry. And the work can be made quite difficult with special anatomical situations, like the retromandibular vein that you can see here under the facial nerves, and one of the branch of the veins is passing over and then under again, the facial nerve branches. Okay, so on this image you can see the relationship. At this part I have taken the masseter muscle off to see better the relationship with the bone. And you can see here the relationship with the submandibular gland. Here once again, so the submandibular gland surgery is quite frequent for stones. Nowadays we try to do it with endoscopical techniques as well, but quite often the classical removal of the gland is a must, and in this case the branch, the nerve can be very, very close. So the classical scholar idea is to make an incision like 3 centimeters under the mandibula to be sure to protect the nerve. So I repeat that I'm not a plastic surgeon, but I like this image because it shows the position of the nerve, so over the masticatory muscles and under the subcutaneous musculoeponeurotic system. Okay, so how about the trauma? The source of the trauma can be different, like microtraumas, crush, traction usually by the student who is assisting, who doesn't know what kind of force and direction to use when he's helping the surgeon. Transection may occur, ischemia, thermic electric effect during coagulation, or cicatrization, and post-operative edema can lead to facial paralysis. So about the classification of the damage to the nerve, Sunderland is the classification that is used all around the world. 5 cases were described. The most simple was neuropraxia, when the morphology of the nerve is intact and just ionic changes occur, but without, so you see the nerve, it's okay, but there's a paralysis. And it goes to total tear. The House-Brackman grading system is well known in a passive and active state of the face, from normal function to no motion at all. When trauma occurs in the area of the face, usually the paralysis is there, it's not a surprise. So this was a traffic accident. But with doctors, they cause damage as well to the nerve. Iatrogen is responsible for about 5 to 7% of the cases. Cosmetic surgery, 11% of these cases. In ENT activity, 25% coming from parotidectomies. And oral and maxillofacial surgery is the great, I'd say, criminal, if I can afford to say that. And in the literature about parotidectomy, about 10 to 30% of the interventions is accompanied by paralysis. About 10% is described as permanent. I tried to touch something of wood. I had only one facial paralysis, and that was transitory. So about the study, there are several options to analyze the nerve. You can use fresh human corpses. That's what we have done. And the defunts were stored in an ambient temperature of 6 degrees, not longer than 2 days. So as you have shown us yesterday, the quality of the muscles is like in living creatures. And in Hungary, I had the chance to have access with ethical committee's agreement to these dissections. Also, you could use formalin-conserved cadavers, but the rigidity and the ability to manipulate the nerve and even the position and the reactions are different, and so we didn't opt for this. And surgery as well, but in this case, it was said once again in Budapest that the simplest just is superficial parotidectomy, but nowadays we believe that in case of isolated tumor, benign tumor of the inferior pole, like pleomorph adenoma, for example, you can make partial superficial parotidectomy. So making this kind of experiments is not justified during surgery. You would think that one could think that when achieving cadaver dissections, it's okay, there's no problem, no bleeding at all. But especially in anticoagulated patients, bleeding may occur, and it can be very important as well. Very interesting anatomical situations may occur, like in this case, you can see here the styling process, which is forming an articulation with a high bone. So the mean length of the styloid process is around 2.5, 3 centimeters. In this case, it was 8.5 centimeters long. Also, you may find during the dissection some tumors, and you can see here the relationship of the nerve with this tumor. So imagine how hard it is to prepare in a living surgery. Also, you can find some other situations in this patient. Cholesteatoma was operated, and a pearl, a recidiva, can be seen here. It can be quite important because when you achieve a parotidectomy, usually you find the trunk of the nerve with the posterior belly of the digastric muscle, with a suture or the pointer of Conley. But if you have difficulties, you have to use the retrograde preparation technique. And if it doesn't work either, you can make a mastoidectomy, find the nerve in the bone, and follow from there. So as I've told you, the surgeries were done in the morning, and I was working with two fellows who were working at the University of Technology, engineers. I let them work sometimes, and here you can see a small lesion. This is the epineurial envelope that has remained intact. No total disruption did occur, but it's there. There's an anastom was before, after, so I'm not sure it would cause problem. Also about the paralysis and the consequences, which is important to know that the lateral palpebral line is a limit. So if you cut a nerve after, the branching is so important that there's no sequela, so you don't have to suture the nerve. Okay. Here another example which was more serious. You can see that the epineurium, this connective tissue full of collagen, still keeps. And this was a total disruption of the marginal branch. Okay, just to show you some of the images, stereo microscopic images. This was an intact nerve. Here, the tearing has started, and the envelope can be seen there. The nerve fibers, I would say, are here and here. But recovery may occur. Okay, an example of the epineurial continuity, and a nice total tear. Okay. So about the results, we have had the chance to operate 31 corpses, representing 55 hemifaces, the majority females. Left and right ratio was the same, and the mean age was over 70. It's quite important because the position of the tissues, like in gynecology, the enteroptosis, the descent of the uterus, it occurs as well in the face, as we know, so the position of the nerve could change. The difference in numbers was caused by hemorrhage, autolysis, and simply because we had to leave in some cases earlier. So about the branches, we had altogether 70 marginal mandibular branches, and there was one branch in the majority of the cases, but as you can see, there was a difference because on the left side, there were more duplications of the nerve. We are looking as well for the origin of the nerve in two planes, in a vertical and a horizontal plane. So horizontally, the origin was mostly pre-mandibular, before the mandibula. And vertically, mostly over the mandibula, and more sometimes under the mandibula, mostly in case of male patients. The course, the classical course in all books is submandibular, so that's the reason why we had to cut under. And yes, that was right, the majority was submandibular, but quite a number of cases, so about 1/3 of the cases were along the inferior mandibular rim or even over. But we cannot be sure. We cannot detect it before the surgery. And the rule in ENT head and neck surgery, I don't know plastic surgery rules, is that if you use a nerve stimulator, you don't get better. So it's just for teaching results. You have to know the anatomy, you have to adapt yourself, and you have to make a meticulous preparation. That's the key point. Okay. So collaterals were present in some cases, mostly relating the buccal and cervical areas, and especially in female patients. Anastomosis. was found in about 16% of all these mandibular branches, mostly females, mostly on the left side. I don't remember the name of the author from Brazilian School of Sao Paulo. In the Journal of Maxillofacial Surgery, they have found around 60% of anastomosis in case of this branch, which was quite high. Okay. This is about another presentation, so to show that our numbers concerning the number of branches in the parotid gland and in the area of the muscles was almost like in the study of Zaphetantersis. So some of the conclusions from the study and the literature, the seventh cranial nerve is the most often damaged cranial nerve in traffic accidents as well, despite of the epineurium, the covering skin, fat tissue and others. And head and neck surgery may do damage the branch, as this is the most often dissected branch of the nerve. And of course the paralysis, the chances of morbidity are correlating with the length of the dissection, which is quite logical. The morphology of the nerve is unstable and we must always be vigilant. It's not a routine surgery. So in the study there was one branch present in the majority of the cases, a mean of 1.75 per hemiphase. Double branching was most frequent on the left. Usually the nerve originates behind the mandibula. Inframandibular origin is more frequent in males. Submandibular course in about 2/3 of the cases. And especially in females, collaterals and anastomosis may occur. So the chances of recovery are higher in case of ladies. Okay, and thank you very much for the attention.
Thank you very much, Dr. Robert. Excellent your presentation, very didactic. And the questions we can put, if you have, at the end of the session to all the speakers.